I'm Matt Martinez. I'm going to talk about the role of MRI. You've heard kind of smatterings of this already throughout some of the talks yesterday. We're going to try and expand on that a little bit. So when we talk about evaluation of the athlete, hopefully you've gotten a flavor, or you're doing this already, that it's really a comprehensive assessment. There isn't a perfect way to sort this out, whether it's history or physical exam and the role of the electrocardiogram, or when you're talking about imaging. There isn't any single best test, whether it's echo or MRI or CT or stress testing. Depending on the question, depending on the patient, each of these can have merit over the other. But if you look at all the causes of sudden cardiac arrest, whether it's left ventricular disease or right ventricular disease, it's an aortic disease, it's an acquired disease or a valvular heart disease, it turns out MRI identifies all of them. So when you're looking for a comprehensive test, this may not be the first one you go to, but it should certainly be on your list of things to consider. So recently, the ACC, I feel like I have to address that. There was a discussion about asymptomatic screening using MRI. It got a lot of press, and whether or not we could just screen athletes using MRI. And Ben Levine and I wrote an editorial about it and came to the same conclusion, that it's probably not ready for prime time. And based on some of the things here, like technical aspects, availability, expense, expertise, and interpretation, MRI is probably not going to be the screening test we're all looking for. So I would recommend against this for asymptomatic screening of athletes above the other things we've talked about. But it clearly has a role. So if you look at MRI, I break it up into three pieces. It sort of comes in three flavors, the first of which are these two here. Now, none of these require ionizing radiation. None of them require contrast. So the safety of these is pretty well established. Without contrast, we do this in pregnancy, we do it in young kids, and we do it in old folks. Everybody and everyone in between. So black blood imaging is the oldest of the three techniques here. They're still images, best for edema or morphology. They're high resolution images. If you want to do a specific small entity by MRI, this might be the tool you use, but it's a small number, maybe on the order of 3 to 5%. The workhorse is this one in the middle, often referred to as Fiesta if you're using GE, but they are motion images, as you see here. They look for morphology and they look at function, and again, no ionizing radiation, and it doesn't require contrast. So you've seen echo images, and I'll show you some MRI images. Hopefully you're seeing already the quality of the images is superb. It makes the ability to look at wall motion, function, stroke volume, assessment of both the left and the right heart easily can be done by MRI. So it's really considered the gold standard for a functional analysis. Most of the time, this is what we're using in studies looking at wall motion, stroke volume, LV mass, RV function, congenital heart disease. This is our go-to because it's the most reproducible over all the other techniques. And you've heard all about this already, because the measurements matter most in the athletes, because the wall thickness is different, and there's a cutoff where we typically don't see this, whether it's an NBA athlete or an NFL athlete, making sure we're accurate in our measurements, 11, 13, 17, very different considerations depending on that wall thickness, and the same thing with chamber size. Many of the time, the athletes, 30 to 50% of the time, you'll see a bigger cavity, and having that specific knowledge that it's an athletic heart is important. One of the folks who reads near us routinely calls severe biventricular dilation for 58 and 60 millimeter ventricles. It really gets it complicated down the line because I'm undoing a written report. So making sure that you're on top of your referrals and talking to the radiologist or the cardiologist who's interpreting these, because the numbers matter. But it goes beyond that. We can look at the aorta, valve assessment, and scar or fibrosis all in a single study by MRI. So here's some examples where you can look at the entire aorta. So this is front of the body, liver, aorta. This is the candy cane view, hopefully for obvious reasons, where you can get a look at the entire aorta when you're looking for diseases like Marfan syndrome, like this one. Because Marfan, like many of the aortopathies, doesn't involve just the ascending aorta. It can involve the entire aorta. So getting a single study in a 15-year-old who you're concerned about, without radiation, without contrast, my go-to is 100% of the time MRI. I don't like radiating people for no good reason. Same thing with valvular heart disease. Can I wand over this and make it work again? Now, valvular heart disease, sometimes you're looking for morphology. Is this truly bicuspid? Is it quadricuspid? That's important, often better than transthoracic echo. And looking at anomalous coronaries can often be done with a single study. So when I'm looking for this, often I will get all of this in a single study. So that's why it's become so important to look for hypertrophic cardiomyopathy with and without obstruction and other diseases, right ventricular cardiomyopathy, dilated and anomalous vessels. So here's an example. 17-year-old soccer player, breathless for 2 months, no syncope, no family history of sudden cardiac arrest. He thought he was okay. His trainer said, something's not right. You're just not getting better like everybody else is. You were breathless when we started. You seem to be more breathless now. Send him for a referral. Here's his echo. Not sure why this one's having small seizures there, but it seems to be getting over it. I can tell you the wall thickness was read as normal. There was no outflow tract obstruction, really no significant valvular heart disease. But when we got to Doppler, what we found was that there were some problems. This is not a normal Doppler. There's abnormal relaxation within the heart, which is a sign that there may be some myocardial disease. So it's more than just the wall thickness. Thinking beyond that and understanding those echo reports is critical. So we sent him on, hopefully, for whatever the next step is. So you could argue many of these are appropriate. Stress echo wouldn't be unreasonable, an echo with strain imaging. I probably wouldn't CT this young man, but this is a talk on MRI, so hopefully you would have guessed MRI. So that's what we did. We sent him on for cardiac MR, and hopefully you're seeing that there is a marked difference between the septal wall here and the lateral wall, inferior septum here and here. Clearly hypertrophic cardiomyopathy, an entirely different view of the myocardium compared to the echo. And we know this. We heard this yesterday from David Owens, and there are multiple studies now showing that if you have normal muscle next to abnormal muscle, the sonographer may screen one way or the other and make the ventricle look normal, right? You can make an abnormal muscle look normal depending on how you slice through it with the echo. It's not perfect, neither is MRI, but we're able to get a better look at the entire ventricle in one single shot. Multiple studies have shown that even if we identify hypertrophy, MRI often gets a better look at the significance of the hypertrophy. So you heard yesterday when we talk about diseases like hypertrophic cardiomyopathy, not all that's thick carries the same risk. 15, 20, 35 millimeters thick septums have very different risk factor profiles and should prompt a different discussion. So knowing the accuracy of the wall muscle, of the wall thickness is critical when you're evaluating somebody with hypertrophic cardiomyopathy. Again, we're back to T-wave inebriation. This is something that should pull a trigger for you. If you see a T-wave like this could be the start of something sinister. The guidelines, I think, are pretty clear on this. If you find T-wave inversions out through V5 and V6, you really should look further. And this is the reason why. There are a number of reports finding that up to 5% or so will convert. So remember, this is a disease that is a continuum. It doesn't start normal and become grossly abnormal 2 weeks later. There's a process between 15 and 20 and 30. And we used to tell people that it never gets thicker after you're 20 or 22. Probably wrong, because I have a number of folks who are thicker into their 50s and 60s. I have a number who have positive genes in their 40s who have normal LV wall thickness. There's just more to understand about hypertrophic cardiomyopathy and the other pathologic diseases. So if you see something that's concerning, it should prompt further investigation, and the guidelines, I think, are pretty clear. It should be routine diagnostic for an ECG that looks like this. I usually skip the echo the next time they come around. Somebody asked yesterday about getting them approved. I've never had trouble. So when they block it, I call, and I'll say I'm skipping the echocardiogram because I want the MRI. If I get the echo when it's normal, I'm still going to do the MRI. So let's just skip the echo. So it's a 5-minute phone call. Most of the time you get a human being on the other side that has some understanding and some thought process. I've not had trouble with it. It is 5 or 10 minutes out of my life that I'll never get back, but it's a lot easier than ordering an echo and then an MRI. So I've never had trouble with it. If I find this ECG, I typically skip the echo the next year and go directly to MRI because I need some reassurance that nothing else is happening, especially in areas that we have trouble. Oops. Like apical hypertrophic cardiomyopathy, where the echo may be suggestive but not diagnostic of clearly apical hypertrophic cardiomyopathy. and helping identify that sinister pouch. We know that if there's some pouch formation at the tips of the ventricle with hypertrophic cardiomyopathy, the outcomes can be worse, and it's often associated with scar. Higher risk for VT, higher risk for heart failure, higher risk for thromboembolism. So identifying this and acting on it is critical beyond the diagnosis. So regarding scar, which of the following is correct? It's needed for return of play. Prior evaluation it's only necessary prior to myectomy. It helps risk stratify hypertrophs, or it's typical to find in athletes. Hopefully you've heard this already and you know that this is really primarily for risk stratifying patients. It can help with the diagnosis, but it's not in itself enough to make the diagnosis. So up till now, no gadolinium, no contrast, really no IV for most of the patients who need MRI, unless you're looking for fibrosis or scar. So these are images that they give contrast, wait 10 minutes or so, and they do specific sequences to look for normal black myocardium compared with abnormal white myocardium. And that white myocardium, by and large, in general, is abnormal. We used to say white is dead. That's not true, but white is definitely abnormal. So the presence of late gadolinium is not enough. It's not dichotomous. It helps you. The pattern of late gadolinium enhancement is critical. And there's a slide coming that will help illustrate that. I hope any moment. There we go. So you can distinguish between ischemic, subendocardial infarct, and transmural infarct. That may help you in some of the older folks you see, but the pattern matters. So where the description is can help identify which of the non-ischemic cardiomyopathies this is. So if it's mid-wall stripe or epicardial, that's going to lean towards myocarditis. If it's a patchy pattern, you're going to think more about sarcoidosis. If it's in the RV insertions or in a thicker septum, of course, this is consistent with hypertrophic cardiomyopathy. And we see this pattern, and it helps us better identify, is it an infarct, or is it HCM, or is it myocarditis? Obviously, this is going to help you with diagnosis, but it's certainly going to help you with management of that person as well. So it's not just the presence, but the pattern that helps you identify and manage the folks with a cardiac MR. So exercise has been described quite a bit, and you've heard about remodeling of the RV and the LV and arrhythmia, and in the last few years you've heard more discussion about whether or not exercise induces troponemia, coronary artery disease, which you'll hear whether or not this is true later on today, and even fibrosis. So there are a number of small reports that describe this. One in 2012 was the one most often reported, and they talked about how baseline to post-race there was a change in the RV cavity, and others had described that the strain becomes abnormal inside that septum, and perhaps that was the reason why we were seeing that scar. But the truth is we don't know what that is. We're not sure if it's relevant or not. It's seen in other diseases like pulmonary hypertension, RV strain, congenital heart disease, and there's much more work to be done before you get too excited about it. But there are a number of studies this past year that helped. So here's a study from Dallas looking at groups of athletes over the age of 60, and they broke them into group 1 through 4 based on how often they exercise. Group 1 the least amount, group 4 5 or 6 days per week. And what they found was in that group, late gadolinium enhancement was basically undetectable, pretty rare. And what they concluded over that large group here was that lifelong physical activity, regardless of dose, how much you do, is not associated with myocardial fibrosis. Just a single study, but it does lend this to whether or not the presence of fibrosis can be ignored. Here's myocardial fibrosis in the athletes. It's a meta-analysis done by Paul Thompson and others looking at this. And what they found, if you put it all together, is that MRI fibrosis is unusual. It's occurring in about 5 or 6%, mostly in the older athletes. But if you dig a little deeper and you say those under the age of 40, which is the ones that I'm mostly concerned about for hypertrophic cardiomyopathy, heritable type diseases, you go down this list and you'll find that across the board, myocardial fibrosis was undetectable, pretty rare. About 1%, 7 out of 509 patients completely, and 5 of those were in the acute phase, meaning they raced and then they jumped in an MRI scanner within a day to look for myocardial fibrosis. I'm not seeing a lot of those athletes come to me within a few hours after their marathon just to see if they have new scar. So I'm not sure what to do with that. Is it transient? Is it related to a virus? Were they sick and we didn't know it? Is something else happening that we don't understand? Because we know fibrosis is bad, so its presence should imply a bad outcome. So I'm happy to see that it's unusual. So if you see it in an athlete, a 22-year-old who has scar inside their septum, I would argue that you need to look deeper. That's someone you should lose a little sleep on and think about whether or not they have hypertrophic cardiomyopathy or some other disease. That's somebody you want to hold on to and keep them close. So in the last 10 minutes, hopefully I showed you that MRI is valuable in the assessment of the athlete. It can help you with coronary disease, aortic valvular heart disease, and of course, myocardial disease, whether it's LV or RV. So the take home is that MRI helps you with wall thickness, being sure what your diagnosis is or that it's normal or not. LV and RV chamber size, it does both of these with high reproducibility and often considered the gold standard. And LGE is unusual. If you see it, it should prompt you to get a little bit concerned, especially in those under the age of 40. In that older group, it should have an ischemic pattern, and then you're going down the coronary artery disease route. I think it's an important tool for the symptomatic athlete. It's helpful for the athlete with unexplained findings and that gray zone, that 13, 14, 15 millimeter thick septum. I want to know how thick it really is. I don't think it's the first test you'll go to, but it should offer you a deep dive into that athlete that you may be losing a little bit of sleep over and that you have to be crystal clear about. And that's all I have.